Well, I'm really excited today to learn something new. Something, and I already have by just looking at the sheet that they handed out. I've already learned something new. But I want to thank Diane for getting together a panel for us on a very serious subject of strokes. So Diane, bring your people, and thank you very much for coming. Let's welcome them.
So when Shara approached me about a topic that I might be interested in sharing, this is one that I kind of came up with, and it is with a great pleasure that I have Dr. Dennis Michel sitting here next to me. Many of you may know or may not know, but Dennis was one of the early 7 families of this church. So we have known him for over 30 years. And he may have been a doctor and still is a doctor, but he was still humble enough to come in the early times when we were meeting at the gym and bring a trailer load of sound equipment over and set it up each week. And he and Dave Meadows did that, and then Harry Hooper and Gene would set up the chairs, and we did that for a long time before we even broke ground on the building that we're sitting in right now. So anyway, I contacted Dennis. He's semi-retired. He's still working at Sutter Urgent Care Centers now. And so he was said he would willingly come over here and share with us. The way we're going to do this is each one of us is going to share an experience we've had with strokes with our own spouses. And we're just going to kind of open it up and share that real briefly, and then I'm going to turn the microphone over to Dennis to talk about them as a whole. So some of you may have heard the story and some of you may not, but it's been 6.5 years since my husband Gene had a stroke. And his stroke was a cerebellum stroke. And what actually happened, we found out much later, was back here there's a vein going up into the brain, or an artery, vein or artery?
Both.
Both. And he probably got a piece of plaque caught in it, and it cut off the blood flow to his brain. And at the time, of course, we didn't know that. And that's very common, that when strokes occur, they don't always, nobody tells you right away that they're a stroke. We were down in Calaveras County visiting my Uncle Bob. We had driven down there. It was a regular Monday morning. We had gone, I can't tell you how many times we've driven down to Uncle Bob's house, and we had just gotten there, but we had stopped in Jackson and had breakfast at Mel's. So when we got to the house, I went in, and so did Gene, but he didn't tell me that as we were making the corner curve right there, he suddenly had this splitting headache. And I came into the house with him, and then I went out to the barn to talk with his caregiver, Uncle Bob's caregiver, and I suddenly heard Gene vomiting ferociously on the front porch. And my first thought was he must have food poisoning because he had just had breakfast. So we kind of just put him back in the vehicle, the truck, and I drove him home. Got him cleaned up, and he went to bed, and I prayed over him and thought he had food poisoning or a sudden case of the flu. And it was about an hour later that he distinctly said to me, as clear as could be, "Would you call the doctor's office?" And when he told me that, I thought, wow, he's never asked me to do that before, and I did. I got somebody on the phone, and I'm sure that while he looked at Gene's file on the computer and he heard the symptoms, he knew what had happened, but he didn't want to scare me. And he said, it could be food poisoning, it could be the flu, it could be dehydration, but I think you should take him into the emergency room. And when I did, is when they diagnosed him as having a stroke. It was about another 36 hours later that we found out that his brain had swollen immensely, and if you realize it, your brain's inside the skull, and that's a pretty hard skull, so it doesn't expand. So they had to literally cut him from the back up to the very top and open up the skull to let the brain get the swollenness off of, but also they took out a portion of his brain that had been destroyed. And that's a part that is major, is the stroke causes damage to the brain. So anyway, Gene is a walking miracle, in case you haven't quite figured that out. And so I'm grateful every day that he's still with us. So with that, each one of us had a different experience. And that's why we're up here to share how different they can be. And that's another reason why these forms were passed out, to just kind of help you get an idea of what to look for. Sandy?
Okay, thanks. I'm going to talk about Jack. And his experience was totally different than Gene's. Bottom line is what Jack had was called a TIA. That's a transient ischemic attack. It's an attack on the brain where the symptoms don't last. They're usually gone within 24, 48 hours. But when it's happening, they present as a stroke. And he was sitting here in church in the same seat he's in right now. Church was just over. Jack has Parkinson's, so sometimes he doesn't stand up to sing. And when the last song came and he didn't stand up, I didn't think anything of it. He does that a lot. So when the song was done and I looked down, he was slumped to his right. He couldn't speak. He was drooping on the right and drooling. When I said, "Can you squeeze my hand?" there was nothing. He was not responsive, basically, at first. So as a nurse, I said to myself, he's having a stroke. And I said to Henry, call 911. So he did. And the good thing about having an emergency in church is all your friends gather around. Betty Lou was praying over him. Everybody, when the paramedics came, they said, "Excuse us, but we have to get in here." So that was a bonus to have all of our friends praying for him and for me at the time while we were waiting. When you go to the emergency room in an ambulance, if they think you're having a stroke, your gurney goes to the head of the line, which he did. And they whipped him off for a CAT scan. If you're having a stroke, it'll show either a clot or it will show a bleed in the brain. They came back, Jack had neither a clot nor a bleed, which means he did not have a stroke. He had what they call the TIA. Some people call them a mini stroke. You have the symptoms, but like I said, within about 24, 48 hours, the symptoms are gone and you're left like he is left with no repercussions from this. But a couple of things that I just want to bring out. Praise God that he's okay now. This list that Sheila put together, thank you for doing that, talks about different things, and some of those pertain to him and some of them didn't. And the thing that stands out here to me, though, is, this is just a personal note, but I have no qualms with calling 911 if I think we have an emergency, especially if I think it's a heart attack or a stroke. Those two things. So when this says call or take the person to the ER immediately, I go, no. Call 911. When somebody's having a stroke, time is of the essence. As it says here, there's a drug, we call it a clot buster, that they can give a patient if the MRI shows that the patient has a clot in his brain. They can give him that medication to start dissolving that clot and reduce the damage to the brain tissue. So this is kind of where I differ with this. This is my own personal opinion, but I'm thinking if somebody's having a stroke, if I'm having a stroke, call 911. Okay? Don't throw me in the car and drive me. You know, when you're driving that patient to the ER, bad things can happen. They could start convulsing on you. They could die on you. So call 911. That's the advice from me. And like it says, time is of the essence, because that drug has to be administered within, 72 hours, I think.
No, 3
hours.
2 to 3 hours.
2 to 3 hours, yeah. So, like I said, time is of the essence. So, anyway, praise God, Jack is here and he's doing well.
Well, Lowell's stroke was an ischemic stroke, so it was more than the TIA that Jack had. I'm going to pass this to him and let him tell you. I'm going to kind of do a chronology.
Okay, so mine happened on February 19th this year. And I woke up, we both kind of slept late. I woke up and my left leg was numb. Well, I have sciatic pain from back injuries. And so that normally causes my left leg to get numb. So I thought, gave that excuse. And then I also noticed that I was, just a couple times, I just kind of drug it, like it was not working. Oh, that's kind of weird. But nobody gives you instructions on what to do. And Sheila was still asleep. So, and I didn't see myself in a mirror. I didn't look at a mirror right away. Otherwise, I'd have noticed that my left side of my face was drooping slightly. So I kind of went about our day. And we had a late, what do we call it, breakfast or lunch at Sheila's favorite restaurant, McDonald's. And let's see, you want to talk about it?
To back up just a little bit, I got up, went in the bathroom, did my makeup and my hair, and then I came out to where Lowell was in the great room, and he was sitting in his chair, and he looked fine. So I said to him, well, you ready to go to McDonald's and get a burger? And he said something to me, but it sounded like gibberish. That should have been my first clue. But you know, I think I was just in denial. Yeah, I want to go to McDonald's and get my burger. So I thought, that's weird, but I know that he has dry mouth sometimes. Maybe he's having a problem with his dry mouth. So I said, Lowell, are you having a problem with your dry mouth? And then just as clear as a bell, he said, no. And I thought, oh, okay. And I said, well, let's go then. We go to McDonald's. We're standing in line, getting ready to order our food. And I'm not kidding you. He was standing there and just barely swaying side to side. And I looked at him and I said, Lowell, do you know you're doing this? And I demonstrated for him. And he said, no. So I thought, okay. We got our burger, sat down, ate. And afterwards, we were going to go over our Bible study lesson. We have a family Bible study. And we did that. And then we were through with the lesson. And all of a sudden, he said, you know, I don't think I can do this. And I thought, that is not my husband. He never says he can't do something related to Bible study. And what he meant was, I don't think I can lead the study tonight. So I looked at him and I said, what do you say we take a little trip to the ER? And that's when we left to go to the ER. So by now, it's probably 1:30 in the afternoon. A long time has passed, and we're too late for the clotbuster. So let me have him tell you what happened when he got to the hospital.
Could have gone to either Kaiser or the VA. And the times that I've been to Kaiser, it's always been impacted. And no matter what time of day you go there, it's like a 6-hour stay. And so I thought, no, it's closer, let's go to the VA. So we went to the VA ER. And I'll tell you, in fact, I looked at my watch. Within 35 minutes, they had me on a gurney going to get a CT scan. So they were really quick. And what it showed, in fact, they did one without a dye and then one with a dye. But the point is, it showed a spot on my brain about the size of a dime that had been basically hit by a clot.
Okay, so when we got to the hospital, I said, do you want me to walk in with you? He said, no, I'll walk in. So I thought, okay. So in he goes. I park the car. By the time I get into the ER area, and this is like maybe 5 minutes, he's already in a room in the ER. And I'm thinking, whoa, I walk in the room and there must have been 6 people in there, and I thought, oh my gosh, this is serious. And he's proceeding to tell them that he got up that morning and his leg was weak and da-da-da-da. I didn't know that his leg was weak, that he said he had a headache, he told him. I didn't know any of that, which is part of the reason I didn't pick up on what was going on. You know, I wish I had, but you know, God's in control. So, and we're here. Your turn.
Okay. Well, good afternoon, everybody. I'm going to move this a little over so you won't think I'm ignoring half the group. Now, first thing you notice is the stories were very different with the 3 families, wasn't it? And both Diane and Sheila and Sandy had different clues that they had to pick up on, but it took them a while for things to settle in. And that's what we're trying to maybe overcome a little bit today. So, let's get down to the basics first of all. What is a stroke? Now, they've already shared a little bit. Stroke is essentially interruption of blood flow to one portion of the brain. All right? That interruption will result in brain tissue damage if it's not corrected in a short period of time. It's not unlike interrupted blood flow to heart muscle when you are working on a heart attack, right? Except it's up in a different tissue area. So a brain attack is really what a stroke is, all right? A TIA was mentioned here by Sandy. A TIA is basically a brief interruption of blood flow to a portion of the brain that then results in neurologic symptoms, but those symptoms go away when the blood flow returns to that area of the brain and it hasn't been deprived long enough to kill brain tissue. So a TIA, transient ischemic attack, doesn't have to be milder than a stroke. If I listen to these 3 stories, I think the symptoms that Jack had were more severe than the others. Loss of consciousness, unable to respond, facial droop and drooling and those sort of things. But he was completely unresponsive. Turns out, by the time he gets to the ER, symptoms are going away and he's feeling better. Now, most TIAs, again, think angina. It is pain or dysfunction in the brain that if you don't do something about, may end up with brain damage permanent, which is, again, a brain attack. So it's sort of a pre-stroke. The thing about TIA is in the name, transient, right? Transient ischemic attack. Most TIAs, symptoms are better in 1 to 2 hours. If it lasts longer than 24 hours, it is no longer a TIA, by definition. However, there is a 3-day window where you could have, we call a reversible neurologic deficit, and those symptoms last from up to 72 hours. And after 72 hours, if you've still got symptoms, it's a stroke. Okay? The TIAs are a warning, and they're an important warning. 15 out of 100 people that get a TIA like Jack had will have a stroke within 3 months. 1/3 of the people with the TIA will have a stroke within a year if untreated. That's 33%. That's a lot of people. So very often TIAs are going to turn into a stroke if you don't do something about it. So what? We're going to test. We're going to get to the cause of what caused the TIA if we can, and then we're going to address that. And that's something we'll circle back on in a few minutes. So let's take a look. How common are strokes? Anybody here either have had a stroke out in the audience or know a family member with a stroke? Could you raise your hand? Yeah, a lot of hands go up. Third most common disease behind cancer and heart disease are cerebral dysfunction like strokes. 15 million people around the world each year get a stroke. 15 million per year. All right? So, when that gets added up very quickly. How many over 5 years? 45 million people. It's pretty significant. Now, it's been brought up that there are different types of stroke. We've already talked about TIA, which is sort of a warning stroke. But a stroke where you have interrupted the blood flow to the brain is usually going to fall into one of two categories. It's going to be ischemic, like we had over here, or it's going to be hemorrhagic. And both of them have to do with some problem with the blood vessels supplying blood and oxygen to the tissue, to our squash up here. And if we don't have oxygen, tissue's not going to survive. So ischemic, usually it is an interruption of blood flow from a clot. That clot could be sent from the heart if you have atrial fibrillation and make clots in your heart. You can push a clot up to your brain. People that get clots in their leg, those clots, if they travel, they don't go to the brain, they go to the lungs. And people get pulmonary embolisms, right? But if it's in the other side of the system, the left side of the system, the heart pumps out to the body and to the brain from the left side. If there's clot in there, which we frequently get in atrial fibrillation, you can push a clot up to the brain. Second would be a clot that may occurred when someone's carotid artery plaque, their neck artery is narrowed maybe 90%, and the plaque, which is on the edge of the artery, kind of rips and ruptures, and the process of that injury to the plaque can cause clotting to occur. And that clot could be right there in the neck, or it could travel upstream. Depending on how big an artery or small an artery, where it lands determines what kind of symptoms we see. If someone's got an aneurysm and the aneurysm bursts, they've got a hemorrhagic stroke, essentially. If you have a little tear in the artery because it's weak for some reason, maybe you've been pumping blood pressure way too high year after year after year, and you've weakened the artery, and it just kind of blows like a bicycle tire. It doesn't have to be an aneurysm, it's just a weak spot. You're going to bleed into the brain. Now, as Sandy mentioned, very important, if you go into the ER and you've got a stroke, they can say, ooh, you've got symptoms of a stroke. That doesn't tell us whether you're bleeding or whether you've got no blood flow to a portion of the brain. And it's very important to distinguish between those two, because if we want to give you a clot buster and you've got a bleeding in the brain, you're going to have a massive hemorrhage and die. So you can't give a clot buster to someone who's not got a clot but is bleeding. You're going to make things worse. So it's very important that we know whether or not someone's bleeding in the brain before we think about treating the other way. So we mentioned a minute ago about stroke, and it's different for different people for a lot of reasons, but part of it is, hey, where was the stroke? The blood supply is affecting what portion of the brain, and what did that portion of the brain, what was its role? And not only that, how big was the stroke? If a bigger area of brain damage is going to give you more widespread symptoms than someone that's got a little tiny lacunar infarct, which we see a lot on CAT scans, and nobody ever knew they had it. Little tiny areas deep in the brain, not in the cerebral area, and there'll be little white spots, and those things didn't cause much damage often. If it's bigger, yeah, you see the effects of that. So we want to know, big damage in an unimportant area, going to give you less symptoms than small damage in a critical area of the brain, right? So it's not only how big the damaged area, but is it an important area or is it less important? We have people with left-sided cerebral strokes from the internal carotid artery, right side, left side, kind of coming up into the brain. That hits the cerebrum, and if you have a left-sided stroke, you're going to end up with right-sided symptoms in the arm and the leg and the face. And you might have trouble with language, you might have trouble with numbers, you might have trouble with math, reasoning, written language. If the stroke is on the opposite side of the brain, on the right side, you're going to have left-sided weakness. You might have trouble with music, spatial awareness, art awareness, creativity, and insight. So it's even on the same areas on either side of the brain, different controls. And so that kind of, many of you might have known somebody who had a stroke where they just couldn't speak. They understood everything you said, and they just couldn't communicate. Nothing would come out. Or maybe it would come out gibberish. That hit the language center. But the language center, we've got two. We've got receptive language, receptive aphasia, if that's broken. We've got expressive, so now one of them's understanding the language. That's a different center in the brain than talking the language, producing the language. So you can have one and not the other. My mom turned 93 in April this year, about 2 weeks after she had her birthday, 93. She noticed one day she was just feeling dizzy. She feels dizzy a lot with her blood pressure. She lives at home alone at 93. She noticed a little weakness, and she had some vision changes. Her vision was off a little bit. Calls my sister, who then calls 911. They take her in, and lo and behold, she had had a stroke. They saw changes on the CT scan, but she had atrial fibrillation, which sent a clot to her brain. She never knew she had atrial fibrillation. She never knew she had any heart trouble. But atrial fibrillation, irregular heartbeat, upper chamber quivers but doesn't beat. And in that quivering chamber, clots form. And that, if it starts beating again, the clots go up to the brain. So her first sign of atrial fibrillation was a stroke. And most people that have atrial fibrillation are put on blood thinners to try and keep those clots away so they don't make more of them. She's doing fine. She spent a month in rehab. She's back at home, still getting by with, the only problem is she's not driving like she was. She was driving at 93, in February and March of this year. So we're talking about stroke and the symptoms. What are the risk factors that we are going to put us at higher risk for stroke? Okay? And we've got to look at, there's uncontrollable risk factors, and there's controllable risk factors, right? Modifiable risk factors. So it makes sense. The uncontrollable risk factors like age, we can't do too much about that, right? But over 55, there's a higher risk of stroke. Family history. If you've had two brothers that have had a stroke, that's a strike against you. It doesn't mean you're going to have a stroke, but you have a higher risk of stroke. Race and ethnicity impacts. Blacks have a higher risk of stroke. Asians have a higher risk of stroke. And a little bit below that, Hispanics have a higher risk of stroke. So genetics, and you can't control your genetics. The other thing is gender. We already see here, men, we're all on show tonight, right? Men have more strokes than women, women die more often from a stroke than a man. So if a woman gets a stroke, they may be less likely to survive that stroke. That's pretty significant. And then the last non-modifiable risk factor is prior history of a TIA like Jack, or a prior history of stroke like Gene. So people that have had strokes can have other additional strokes if they don't make changes, right? And do the things that help. We've got a whole list of things that we can control to some degree and treat. We've got the medical side, which would be hypertension, diabetes, cholesterol issues and plaque from cholesterol, circulation problems, atrial fibrillation, like I mentioned before, and sleep apnea causes a higher risk for stroke, and which puts another reason for trying to identify if you're one of those people with sleep apnea. Now, realize there's a whole lifestyle issue that is maybe the most modifiable, but maybe the hardest for us to do. Smoking, obviously, smoking increases your risk of stroke, just like it does heart attack. Heavy drinking can put you at higher risk. Being overweight is a higher risk for stroke. Sedentary lifestyle, not getting out and moving, right? Poor diet, stress, and its impact on the body can put you at a higher risk for stroke. And then poor sleep, kind of tied to the sleep apnea thing. So, there was an inner stroke study that analyzed thousands, like 56,000 people that have had stroke. And they found there were 10 risk factors. We kind of touched on those. I gave you 12 or 13 risk factors, but 10 risk factors accounted for almost 90% of stroke. One thing I didn't mention to you before about ischemic versus hemorrhagic, 85% of the strokes are ischemic. Blood flow is just not there. Clot, plaque, 15% are bleeds. So you're much more likely to have an ischemic stroke than a hemorrhagic stroke. Now, from a medical standpoint, when we're counseling patients, we've got 2 or 3 calculators, medical calculators, that we can input data and see what people's stroke risk are, just like we have for heart attacks. There's a ABCD2 score, and it predicts the stroke risk after a TIA like Jack had. And the things, we're adding points for different criteria, and based on those points, we're getting low, moderate, or high risk. And we're looking at age greater than 60, we're looking at a blood pressure greater than 140, we're looking at TIA symptoms like weakness and speech problems. We're looking at how long the TIA lasted. Did it last over 60 minutes? All of those put together, and we get a stroke risk for those people that have had a TIA. There's a CHADS VASC score for stroke risk in people like my mom who had atrial fibrillation. Considers heart failure, hypertension, diabetes, history of stroke or TIA, vascular disease, how old you are, and what your sex is. And we're not considering what sex you think you are today, but your real sex at birth. There's one other risk factors that we use for stroke risk in diabetics because they have that higher risk. It's called the UK PDS study that looked at 100,000 people in the UK. Big diabetic study. And it considers cholesterol, age, blood pressure, sex, smoking history, AFib history, and how long they've had diabetes. Those are the factors that weigh in that scoring schedule. So it just gives you an idea of some of the things we're looking for and things that impact your risk for stroke. Interestingly, there is an app you can download on your phone today. At least it's in the iOS App Store. I don't know if it's in the Google Play Store. That is a free stroke risk assessment tool. If you fill in the data, it gives you a risk and things that you can modify. And it's called the New Zealand Stroke Riskometer. And it is from Auckland University in New Zealand. Accurately calculates your current risk of a stroke in order to help you prevent it. So, New Zealand Stroke Riskometer. If you type in stroke riskometer into your app store, it will come up and you'll see made by Autel, A-U-T-E-L, which is Auckland Tech University, whatever, down there. And so it's by Autel and it's free. And you could run it, very simple. I don't know if you can get at it online, but you can definitely download it to your phone, put in all the data and get some info. Now, we've gone through what stroke is and we've gone through the risks for stroke. Let's get down to the nitty-gritty. Again, what are the symptoms that we're going to see? Everything was different, right? It was not the same, and if you're expecting it to be the same, you're going to miss it. It's hard when there's confounding things. Numbness in someone who has a history of sciatica and is not unusually to have some numbness. The minute he said weak, my leg was a little weak, that was the red herring that should have flashed up, right? Weakness, and that includes numbness. Altered speech, whether being unable to speak or speaking gibberish. Now, here we had a situation where someone spoke gibberish, and you ask, 10 minutes later, and he gave you, or 5 minutes later, and he gave you an answer that was not gibberish, right? A little confusing. You have to be tuned into these things. Confusion, loss of consciousness, seizures. And here we had it with the TIA with Jack. It wasn't even a full stroke, but remember, the difference between a TIA and a stroke is not the massive degree, it's how long the blood is limited to an area of the brain. The minute the blood comes back, if the brain hasn't died, you're good to go. It's going to go back to normal. If the brain is dead, you can't make dead tissue come back. Okay? Balance issues, dizziness. Some people may call it, hey, I'm kind of dizzy, and what they really mean is, I'm feeling unsteady, I'm not holding my balance, maybe things are moving around. And then the vision changes can be minor, like things are a little blurry, or I can't see on this side of my, both eyes looking this way, don't see anything, but I can see over here fine. So vision changes can be field losses, or they can be a little bit more subtle than that. And you go to your eye doctor these days, they put you in a machine and they kind of figure out where you can see and they map it out. You push the button every time you see something flash and they can get a map of where you see and where you don't see. And if you were to do that right then, you'd have a big area that's all blacked out. You didn't even see when the light was flashing in a particular area of your circular field. The last thing, and we heard of on the stage as well, headache. And a headache can be severe. It's usually not the run-of-the-mill headache. It's like, well, I've got a headache and I'm not a headache person. In Gene's case, part of the problem was increased pressure. So he had such damage to that back part of the brain, and it was not able to accommodate the swelling in there, and that extra pressure. If we were aliens and we had expandable skulls, we could deal with the pressure. But we've got a fixed skull and there's no expansion there, right? And so you put a little extra stuff in there, whether it be swelling or blood, either of those are going to create symptoms because there's no room for those things. They're putting pressure on other areas. And he had to have the pressure released to have everything calm down. Now, you guys have that handout on Be Fast. And again, very important, be balanced, dizzy, eyes, vision defects, face, F is face, droop, tongue can deviate to one side or the other. So, have someone smile, and if one side's droopy, that's one thing. Stick their tongue out and it goes to the side rather than straight. That also can suggest stroke. Weak arms, having people hold their arms up like this. Does one drift to the side? Does one come down? I can't hold it up. Is there numbness in their arms? Speech, slurring, makes no sense. T is time to call. You see those things, you're calling 911. We've emphasized time. It's really important. Why? Time equals brain tissue. The longer that circulation is impaired, the more likely you're going to have permanent brain damage, death to brain tissue, and you're going to have long-term disability. Okay? So, the other thing, as was mentioned before, if we're going to use a clot buster because it's an ischemic issue, there are time limits to using a clot buster. And they figure, ideally, you get people in to get the medicine within 2 hours. That means you have to have all the other tests done ahead of time, including proving that you don't have a bleed in your head. So, longer without getting treatment, we've got more damage, more disability, and we may lose the opportunity to use the clot buster, the TPA, which basically eats away at the clot. So the other thing about the rapid stroke recognition, on the be fast, arms up, stick your tongue out, make a face, have them give you some complete sentences. If they cannot make a complete sentence, if they don't even talk back to you, if they give you gibberish, you got your answer, right? So ask them to give you a couple complete sentences and see what they do. So how do we, you're now in the ER, how do we make the diagnosis? Well, we're going to take a good history, we're going to figure out all the symptoms you had, and we're going to kind of put it together and say that sounds like this or that, and then we're going to try to do some testing to help us with that. Now realize a CAT scan, if you're 1 hour into this set of symptoms and you get in right away, you're eligible for clot buster, right, in that time. If you were to look at the CAT scan, you may not see a stroke. It may not have had time to have visual changes in the brain tissue to show up permanent damage, right? It may be part of that TIA where the brain is complaining, but it's not dead tissue. So we may not see changes of a stroke. That may show up the next day or the day after. But the key is there bleeding? And bleeding in a CAT scan shows up as white. And if we got white in the brain, no clot buster, you had a bleed. Okay? We're going to do labs to make sure that there's not other reasons for clotting to occur. Some people are clotters. They make a lot of clots in their leg. Those clots can be anywhere in the body. We want to identify those people. Is someone already at risk with low blood counts, terribly anemic, we give them a blood thinner and they bleed a little bit, that may get to critical levels. So we want to know what their status is in the blood. And so now we've finally decided, yeah, you got a stroke. Maybe it's an ischemic stroke. What are we going to do? Well, first thing we got to do is support your body. Blood pressure way too high, bring it down a little bit. We don't want to bring it too low because the brain may need that extra pressure to help get the blood to the brain. But we don't want it so high that we're making everything worse. If you have a bleed, high blood pressure is going to pump more blood out of the blood vessel into the brain tissue. We're going to consider that TPA clot buster, but again, 2 to 3 hours is the limit. So what happens? You wake up in the morning, you went to bed at night, you were normal. You wake up at 7 a.m. and you're weak on one side, you can't move. you probably don't qualify for the clotbuster, because that stroke could have happened at 2 a.m., 3 a.m., 4 a.m., not when you noticed it at 7 a.m. So they're not going to necessarily use when you notice the symptoms in that setting if it was already there when you woke up. Now, again, everybody's different and they may stretch things a little bit, but time is of the essence from when it started, not from when you noticed it. You know, for someone like Lowell, who nobody noticed the droopy face that he probably had when he first got up. They didn't notice it for a couple hours, and then later, like, hey, your face is droopy, right? So it's not when you notice it, it's when did it happen, and we don't always know, but we've got this 2 to 3 hour limit to use that medicine. If the blood TPA clotbuster doesn't work, if it's a large artery like in the neck or the internal carotids which come up the side, they can go in there and do an angioplasty, maybe put a catheter up and actually grab and break up the clot and remove it. And then maybe, you know how we do angioplasty on the heart? We put a stent in, right? We go in there and we kind of push the narrow spot open, and those can be done, but only in the large arteries. We can't put catheters way up into the little tiny arteries in the brain. So that has to be a large artery issue. And the other thing that we do is we add the blood thinners. If you have atrial fibrillation, for example, if it was clot because of the heart, we want to reverse the clotting so that you don't send more. It may or may not, so clotbuster is going to help to work on a clot. Blood thinners are going to keep you from making more clots and sending more clots upstream and having repeat strokes. Now, long-term treatment. Well, first you got rehab. Some people are going to end up in a rehab center. Some people are going to end up in a skilled nursing facility, whatever that has rehab. And you might have speech therapy. They're going to have to work on helping you produce sound or understand language because those deficits have hit you. And one or the other of those they can work on. Swallow training, if you're having trouble swallowing because of a stroke, they give you thickened liquids. They work on training those muscles to try to get some of that function back so you don't choke on everything you eat. Physical therapy, it's going to work on movement and coordination. Try to get people up, back on their feet, moving, with a walker or an aid of some sort to begin with, and then maybe those things can be tossed aside later. Occupational therapy is going to try and improve your daily activities. How can we get you back to doing some cooking, some dressing, using the bathroom, stuff like that? That's occupational therapy. And then support group to help with the mental issues. Anybody who says there's not a mental stress or effect to themselves and their family after having a stroke isn't being honest. I mean, that's a big impact, and it takes a long time to adjust. We hope that at the end of that adjustment, people are back to normal, but most people, especially if you've had a real stroke, there's a deficit. Hopefully less than day one, but there's a deficit that has to be worked on that have you accommodate, just like anybody with disability. Someone loses a leg, you fit them with something, you work on getting them out and about, and you see some of these guys with the little funny flipper legs that are running in the Paralympics, right? They've been able to adjust and learn and to get adjust to their disability. And then the last thing is support from family and friends. It takes a lot. In my mom's case, she had kids staying over with her. My two daughters are in the area in the Midwest, and they stayed over with her, 3 days apiece to try and make sure she was doing okay until she got to where she was independent again. So support from family and friends is really important. So the last thing we're doing for treatment is we're attacking the modifiable risk factors. We talked about the high risk of a TIA turning into a stroke. right? If you don't treat it. Well, what does it mean to treat it? Well, it could mean blood thinners. If you had atrial fibrillation, we're going to thin the blood so you don't make things happen. But what about all those modifiable risk factors we talked about? We're going to try to keep your blood pressure under control. We're going to work on getting your diabetes under control, getting the numbers where we want them. It's going to be controlling your cholesterol, reducing your stress, making sure you get better sleep. And then the lifestyle part, not the medical side, but the lifestyle side, if you're still smoking, we're pitching the cigarettes, right? We're having you lose weight. We're looking for better diet, a healthier diet, and we're having people exercise. All of those lower your stress risk, or excuse me, stroke risk. Well, it also helps your stress risk. So, for your consideration, I want you guys to think in a minute. What is your greatest risk factor for stroke that you have right now? You may or may not know what it is, in which case that app may help to identify that for you, okay? What needs to happen for change to occur in that area of your highest risk? What needs to happen? And what do you need to do to make that happen? What do you need to do personally to make that risk go down? Okay? So, in summary, stroke awareness. It's vital as time delays cost brain tissue. So, we want you to be stroke smart. Urgency is the key. Symptoms are often sudden, but they're easy to miss and explain away, right? We heard several examples of explaining away some of the symptoms. Call 911, okay? Being wrong and finding out it wasn't a stroke, that's okay. They're not going to take you out back and shoot you in the firing squad because you called 911 for a stroke and it wasn't there, all right? Call 911 immediately and get something going. They can watch them on the travel in. You're going to get back, even though we have someone here that got back pretty quickly into the back. You're going to get back quicker if you're being brought in by ambulance and they think you're having a stroke. There's going to be no delay at all. They've already called in to the ER and tell them they're coming, so they know. Delay is not okay. Okay? Delay is not okay. So, stroke, react, don't regret. Call 911. And as we said before, be fast. Very nice mnemonic. Memorize that. You have to think about it a little bit. It can be second nature to you if you take that sheet and memorize it. Okay, we're going to have the ladies back sharing about some of the impacts that stroke has had on their lives and maybe a lesson learned.
So we're going to, is it on? Right. Okay. We were just going to close it up right now by just sharing real shortly about, or quickly, about something that we have learned after this experience. And so there was two things, real short for me. One of them is a person who has had a stroke and then comes home requires an enormous amount of patience. It's a real learning lifestyle change, especially in the marriage. And I am very grateful that I am a relatively patient person. Another thing is sleep. I did not know it, but one of the ways that the brain recovers is sleep. So you bring this person home who has had a stroke and they're going to be sleeping a lot. And it just seems so strange, but that's one way with the body and the brain are recovering is through sleep. Sandy?
Okay, I just had two things I wanted to share about 911. You're going to think I'm obsessed with 911, but one thing we learned, I said to the paramedic when they were going to put him on the gurney, I said he needs to go to Kaiser Roseville. And he said to me, no, we are required If he's having a stroke, we are required to take him to the nearest hospital. So Mercy Folsom is where he went, and he got wonderful care. The second thing we learned about calling, if you call 911 from your landline at home, they know where you are. Henry found out when you call 911 from this room, they don't know where you are. So poor Henry, they're saying to him, he said, we got a man here, I think he's having a stroke. What's the address? Henry's going, what's the address? I saw them all going, what's the address? None of that literature in the back of your seats has the address on it. So if you're going to call 911, make sure somebody knows the address of where you are so they can find you.
Okay, let's see. What did I learn? I think the biggest lesson for me is not to doubt what you're seeing. Not to I tried to reason away the fact that he was speaking gibberish. I tried to reason away the fact that he was moving a little slower, that he was just barely shifting side to side. And, anyway, trust yourself. Yeah, trust your instincts.
Well, for me, it's that this happens once in a lifetime, usually. So you don't get any, except for today, you don't get any training in this. I mean, something happens, it's unusual. Okay, it's unusual, but yeah, all I'm saying is it's not the kind of thing that, oh, I've been trained, I know exactly what to do when this happens. Now, if you're a nurse, that's okay, you got that training. But if you're not, and so I think it's a matter of taking the symptoms seriously.
Thank you so much. Did you learn something today? Yes. I think the thing that I learned just listening is that we need to communicate with our spouse. If you're having something that could be a symptom, don't keep it to yourself, right? So I'm going to be talking to my husband about that. Tell me how you're feeling. Thank you very much for coming. Thank you very much. We appreciate you. I have to say that was one of the clearest and best explanations I've ever heard. So I thank you.